Good afternoon, everyone, and thank you all for joining our enterprise-wide webinar on transitioning from fee-for-service to fee-for-value. Before we start, a quick housekeeping item to go over. As Debbie mentioned earlier, all telephone lines will be placed on mute, and when we will have a Q&A session towards the end of the presentation, you ask to dial *1 on your keypad to enter the queue for questions. In a moment, I'll be introducing you to the speakers that you'll be hearing from today. And here is an overview of the agenda for today's webinar. We'll start by providing an overview of the payment models and highlight what's going on in the healthcare landscape, specifically as it relates to public and private sector transition towards value-based reimbursement. And we will be reviewing some of the characteristics of organizations that have sustained success in this fee-for-value environment. Then also discuss how Tenet is positioned to do this value transition. And importantly, outline 3 strategies that you can take away from today's webinar and implement them in your practice to adapt in the value-based healthcare environment. Let me start by introducing myself. I am Dr. Sahana Sharan, and Tenet's National Director for ACO Clinical Operations. I oversee the clinical operations for commercial and Medicare ACO arrangements, and I'm also responsible for building and implementing clinical care management strategies to demonstrate improved costs and quality so we can be successful in the ACO arrangements that we have. We are joined today by our guest speaker, Megan Cox, who is the Director for Division of Financial Risk, Seamless Care Models Group, and Center for Medicare and Medicaid Innovation. She also receives the Pioneer, Full Risk, and Advanced Payment ACO model teams. And Meg holds a Master's in Healthcare Administration from the University of Minnesota School of Public Health. Meg, welcome, and thank you so much for being able to join us today.
Thank you, Sharon. I'm glad to be here.
Let's start first with an overview of payment models. Our 4 broad categories are types of payment models, and you may recognize some of them. It's the fee-for-service model, where payments are based on volume of services and not linked to quality or efficiency, and there is no incentive to optimize utilization or improve quality. And they have the pay-for-performance type of a payment model, where a portion of payment is tied to quality and efficiency. And you are familiar with this model, and some of the examples here include value-based purchasing, which is one of the 3 pay-for-performance programs, along with the readmission reductions program and the hospital acquired conditions program that were introduced as a part of the Affordable Care Act. There is alternative payments model. There was so much talk and activity about this particular type of payment model. Also, it's the most popular model, as it is being widely embraced as the balance between 2 streams of fee-for-service on one end and capitation-based payment model on the other, where payments are still triggered by the delivery of services, but opportunities for shared savings if the provider demonstrates cost savings above a preset target while maintaining quality. And the provider's ability to share in the cost savings is tied to effective management of the populations. And most of the arrangements under this model occur under the broad umbrella of accountable care organizations. You may have heard of or even participate in Medicare's Pioneer ACO, Medicaid Savings Program, and also several other private payers that have entered into the ACO arrangements. We'll see that in a second. Another type of alternative payment model is the bundle payment, where a payer issues a lump sum or a bundled payment to the providers that are involved in delivering an episode of care during a specific time period, which may include physicians, hospitals, and post-acute care providers. And because a bundled payment is smaller than the sum of individual payment that is made to the providers, providers can succeed by reducing input costs and delivering a more efficient episode of care. And then have the full risk-based model, and this is a model that you're very familiar with already, and and I go into too many details here. This is really where providers take on full risk for the populations based on capitated fee per member per month. As we move from the left to right, the population risk across these model increases. And our conversation today will focus around the fee arrangements in the ACO space and shared savings type of arrangements. And simply because this is a sweet spot and the balance between the two extremes of payment models of fee-for-service and full risk type of arrangement. And both the public and the private sector is determined in making this model that is a win-win for patients, providers, and payers. Before we go on further, I want to level set our discussion today with what an ACO is, what an accountable care organization is. A lot of times when I'm meeting with the network or providers, the term ACO is usually associated with the Medicare ACO. While Medicare did introduce the first national scale pioneer ACO model, it's a much broader term. It's really a group of providers that assume and take on the responsibility for the cost and quality of the care that's delivered to the population that's attributed to them. And it's priced of one or more providers of physician groups and hospitals, and care, such as Medicare or private insurers in this instance. Physicians may bill and receive fee-for-service payments for the population and also be eligible to receive shared saving bonuses for lowering the costs that are against a preset target and increasing the quality of care for their assigned patients. And typically, it's either a one-sided model, which is an outside-only model, where ACOs can urge shared saving payments if the total spend for the attributed patient is below a preset target, but face no penalties if the expenses or the spend is above that target. Another type of a model is both upside and a downside, or the two-sided model, where the ACOs can earn payments but also face penalties. Let's look at how public and private sectors are accelerating towards a value-based reimbursement as they're definitively committing to this transition over the next 3 to 5 years. Now I want to turn it over to Meg to talk about CMS's goals as it relates to this transition. Meg, I can advance the slides for you. Just let me know when. But before you do that, Meg, if you could please provide, just introduce yourself and provide an overview of your role, that would be great.
Thank you, Dr. Sharon. It's good to be with all of you today on this call. Thanks for taking the time. My name is Meg Cox, and I come to CMS about a year ago from the private sector. I've spent over 18 years working in healthcare on the private sector side. So I am definitely a hybrid, if not something else. I'm a non-clinician, and today I lead a group at the Innovation Center that is responsible for a variety of models that aim at, I think, what we are all in concert aiming at: high-quality care, better experience for the patient, good physician community care team engagement, and better cost. That group is called the Seamless Care Models Group. As Dr. Sharon said at the beginning, oversee some of the programs that sometimes hit the popular press. The Pioneer program is one of those. The Next Generation ACO model was announced this spring, and we have accepted a number of applications for that. We have received, I should say, a number of applications for that. And then in addition to that, I oversee divisions that include primary care and other initiatives still aimed at finding alternative paths to better value in healthcare. So that's a little bit of my background. You can advance the slide. So to start the discussion of what we're thinking about from the public sector side with an overview of the goals and timelines for moving Medicare forward. I don't expect physicians in practice daily with patients to be following HHS announcements, but we did make a rather bold announcement in 2015 here in the beginning of the year that we hope to move a substantial amount of Medicare payments towards value-based purchasing of some kind. So value-based purchasing can be a term that's used to refer to a very specific kind of contract. Here, I mean it more generically, something other straight-up fee-for-service payments. And so Secretary Burwell announced a very measurable goals and a timeline, moving providers towards payment for quality rather than the quantity of care. And you see here the goals are pretty explicit. So, link fee-for-service payments to quality or value. 85% of all Medicare fee-for-service payments tied to quality or value by 2016. 90% by the end of 2018. Alternative payment models, this would be something like Pioneer or essentially bundles. I think we have a lot of work to do now to define what exactly is going to qualify as an alternative payment model, but moving 30% of Medicare payments to that kind of arrangement by 2016 and 50% by 2018. They're all sort of high-level numbers, and you can throw them and banty them about, but one of the things it reminds me of as I look at this is the conversation that happened shortly after the Affordable Care Act passed in 2010. And I remember at the time I was working in health policy for a provider organization, and somebody said, well, isn't this going to go away? All the politics that was around it, won't this be debated and re-adjudicated at some point? And I said, whatever happens on that government side of things, the movement of healthcare being valued on a basis of the quality that's provided, the overall affordability, the patient experience and engagement in the care. And I don't just mean satisfaction. Did the patient like the visit or not like the visit? I mean true patient engagement. I don't think we're going back on that. I didn't think it at the time in 2010, and I don't think it now. And here you see, now I'm in a different seat, right? I work for HHS, I work for CMS, and I think here we are 5 years later, and we're setting even more aggressive goals for the years out ahead on how we continue to make this transition, where the way that we pay for and we value healthcare is on how healthy we keep the community and how affordably we're able to do so. That's the slide. We've seen there would be 100 slides to show all the initiatives that are at play, but I spoke a little bit about the Medicare Accountable Care Organizations, and that was the focus of this presentation today. And so I wanted to show here that we have a number of them. We have the Pioneer ACO model. Those were the first 32 organizations that led the charge in 2012 to begin being paid on this cost, quality, and experience accountability. We have the next generation ACO model I mentioned a moment ago that we have just finished the application period for that and are currently reviewing applications. That model goes much further in terms of both the accountability that providers take for the health of a population and some of the different we're able to experience with benefits and eligibility, not eligibility for Medicare, but benefits and enhancements for the Medicare beneficiary. The AC initiative is the comprehensive ESRD ACO, so an ACO focused specific on stage renal disease population. And this was really important to our agency. It's not that many patients on any given day for an organization unless you're a dialysis center, and we wanted to engage those groups in improving health and quality for those patients. The payment and ACO investment models are, I call them sister models to the Medicare Shared Savings Program because they actually attach the prepayment of shared savings to the Medicare Shared Savings Program, which is the permanent program. You hear a lot about that. It has the most providers. Its rules are set in regulation and updated through formal rulemakings. It is a more, I would say, from a test of change standpoint, it tends to get updated and then run consistently like that for 2 or 3 years and then get updated again. And in the Innovation Center where I work, the rest of these models I've just discussed, we're operating under a different regulatory framework where we're updating models as they go, and that has pros and cons during the Q&A section. If you have questions about that, I'd be happy to answer. Pros are that if we find something's not working, we can potentially change it faster. Cons are you would draw that line between at least keeping a steady enough test that you can evaluate it in the end. We also have value-based purchasing and the value modifier of Medicare Advantage and Medicare Part D, which are also elements of pay for care on Medicare's part on the public sector side in a way that seeks to be value-based. Both of them are more like bidding products, and I think kind of a different set of questions. But there's the whole spectrum offerings there, and now that I've walked through them, I would just say one of the key questions that often comes up, why not just offer one? It's hard enough to even keep track of everything you just said, Meg. Why not just give us one ACO option and we can sign up for that? And the simplistic and simple and pragmatic loving side of me agrees with that sentiment wholeheartedly. We do hear again and again in public comment to CMS that not every organization is ready to take the same risk in the same way as every other organization of physicians. And that having the multiple options and even the options within each model, Pioneer offered a couple different levels of risk. The next generation model offers the ability to offer enhanced benefits or not to beneficiaries. So we continue to hear support for continue to give us options until we know what really works and what works best and why it works best. So that's why we have the portfolio that we do today, and we're proud of it and proud of what it's achieving and proud of what we're learning in it, even when certain aspects aren't working like we thought. You can advance the slide. An example, this is Medicare ACO penetration today. The different maps available online that take a look at this, but we have more than 405 ACOs participating in the Medicare Shared Savings Program. When we had, Pioneer, what we expect in next generation, and what will go live later this summer with the ESRD ACO, we expect probably on order of another, 50 to 100 there. And I think we're seeing in any of these maps, and in this one in particular, is that you see, lots of involvement in the coast, in urban areas. That penetration into the middle of USA or in the South is something we're still looking for. How do we adapt this alternative payment model so that it speaks to providers in rural communities and providers outside of large urban centers where they have the mass to take the risk? That's what that's about. And you can advance the slide.
Thanks. So arguably, CS is the largest and the only market-moving payer and provides a helpful signaling mechanism for private health plans. We have some of the private sector health plans and parties that agenda towards transitioning towards fee-for-value. It's after HHS announced being providers based on quality rather than quantity. A group of top U.S. health systems, payers, patients, and partners around the country announced the formation of a healthcare transformation task force. It's a private sector alliance that's aimed at accelerating the healthcare industry's transformation to value-based healthcare. And it's a 28-member task force that is comprised of provider organizations such as Advocate, Ascension Health, Partners Healthcare, Trinity Health, and it includes payers such as Aetna, Blue Cross Blue Shield of Massachusetts, Blue Shield of California, ACHC. And it also includes employers such as Caesars Entertainment and purchasers such as Pacific Business Group Health that collectively negotiates on behalf of employers. This task force commits to having 75% of their respective businesses operating under some form of value-based payment arrangement by 2020. And almost every other day, I get news alerts on how private payers are pursuing the path towards value-based reimbursement. Anthem, Aetna, Blue Cross are just some examples of some large payer companies that have committed their goals and timelines to accelerating that transition. And in this value-based landscape, their provider organizations have demonstrated sustained success. So I want to turn it over back to you, Meg, to talk to some of the characteristics of these organizations, more from a national perspective, as you've seen and heard from a wide variety of organizations that have implemented Medicare ACOs, Pioneer ACO, or Medicare Shared Savings Programs.
Thank you. So we have, of course, experienced a lot, and this is by means an exhaustive list. I also would just caveat this with saying that what will sustain success in an individual organization is going to be some combination of these things. They're not in priority order. and really dependent on where you're starting from. So obviously, one of the first and foremost things that people jumped into with ACOs was engaging the data. So receiving full claims data on a patient gives you a look into where they're accessing it, how often they're accessing it. And I think it was really eye-opening for ACOs. It was for me when I ran an ACO to see that for the first time. A lot of data from commercial payers, and we were used to getting risk stratified data and data about care gaps in a patient population and data about patients with chronic and complex conditions, but not necessarily getting the whole picture. And so the experience with Pioneer and Medicare Shared Savings Program has been that Medicare has shared that more or less whole claims data experience. And you're able to say, okay, so I had a patient that had 2 emergency department visits with the hospital I'm most closely associated with, but they also had 6 urgent care visits I didn't know at all. They weren't captured in the electronic medical record that I'm affiliated with or that I access. And so, wow, that really opens a picture that we didn't have before. And specifically the organizations who I think are hanging in there and continuing to be successful in making the transition, engaging providers directly with the data. So I think there's 2 operative terms in that first bullet, engaging providers and actionable information. Simply having access to all the claim line feeds is really not actionable. You need a way to turn that into that tells you who on my patient panel might attention that I wouldn't have anticipated until I see them for the next episode of care or next contact point. And so that's probably all I need to say about that, because I bet I don't need to create data converts in this group. The next is commitment of leadership, and this is a two-edged sword, isn't it? Like, it's not your C-suite that gets this done. It's you daily in your interactions with patients and community, and patients and their families, and patients and community resources. And it's one-on-one. But you must have, we see it time and again, that organizations sustaining success have a strong and sustained commitment from leadership. It can't be hey, this is our initiative for 2012, or this is our top priority for 2015 or 2018. It has to be your top priority going forward, that aligning the care and the services you provide with what is going to generate the highest population health at the lowest cost is your call to action. And it has to be shown from that commitment and leadership that you're saying or no to other things. And so we definitely said, and we see the inverse of it, where there is not that sustained commitment. The minute the wind is not in those sails, you really jeopardize the success of the transformation. Experience in prior alternative payment models or pacing your experience. We don't have a big list of organizations to pull from who I know have been engaged in transformation who said, we're just going to take one giant leap and go all in. Everybody is challenged by and wrestling with fighting the good fight, if you will, to pace their change, pace how much risk they're taking with how much they can ramp up the initiatives and the supports that can be successful in improving patient health. And you get experience, doing that in little commercial contracts you might have, in maybe doing an initiative with your state around your Medicaid population, maybe focusing on just your highest risk patients with a payer for a while, then focusing on all. Maybe you took off, Pioneer first, and it was your Medicare fee-for-service lives and some portion of them who attributed to you that you initially took risk on. But it's a lot to learn a population, and each population is different. So if you have experience in a Medicare Advantage product, a payer comes to you and contracts to say, we have this Medicare Advantage population and we'd like to pay you for performance to care for it. That population, the data you get on them, you're going to get to know some characteristics of that population's needs and what tends to work for them. That's completely different than a commercial product that's ensuring working age, childbearing years for a major employer in the town you're located in, or it's completely different from a Medicare fee-for-service population. So we are finding that those organizations that are having success are not just doing this in one space. They're experimenting with different kinds of alternative payment in different arrangements with different payers, not just Medicare. Definitely many of the organizations speak to the importance of having physicians champions on the front line. I went through the electronic medical record implementation at an organization years ago, and I think back to we had vests that physician champions wore. They were sort of super users, if you will. They received much more training than other physicians on the electronic medical record system so that they could help physicians at the point of care as they were working through going live with that. And that taught us a lot about what it means to make change at that level of care, and that the importance of having peers who you know and trust to be considerate, thoughtful, smart people who care about the same things you do. Invest in learning about what's going on here with payment reform and new modes of care and new aligned payment alternatives. Engaged deeply with it, asked lots of questions, pushed on it in areas, and came out thinking this is the way to go. That goes a long way. It also means that you get better engagement back from your physicians. So we do robust learning system with all of our ACO models. And again, from the ACOs engaged in those learning system activities, that engaging with physicians in that way, both in cultivating and hoping to grow champions for the cause, you also get people who are engaging deeply enough that they can give you good critical feedback. And that's, of course, important. It's not just important to agree all the time. It's important to actually engage and ask the questions. Finally, for sure, the movement to team-based care, population health versus a siloed approach. This is playing out, at least from my vantage point, in many different ways. So you don't go to one ACO and see it and know how every ACO is approaching this. Some may be doing a medical home model. Others may be doing a medical home model and adding really robust process for engaging community and home-based services. Others might take a panel review approach. Others have teams, A team, B team, blue team, C team, that really try to surround us patients and maintain a continuous healing relationship with them. My final point on that before you can move to the next slide is just that it's not there's one way to do team-based care, but definitely growing the supports around a patient in their primary care relationship so that it's not just a one-on-one relationship, but it's a warm handoff to a care navigator or the engagement of a care coach. We're seeing the growth and experimentation really boom in that area.
Meg, that was really great to hear about all those characteristics. So in light of those characteristics of the organizations that have been able to demonstrate sustained success, how is Tenet positioned to handle that transition? How are we aligned, as we discussed and reviewed those characteristics, to reposition ourselves successfully and move towards value-based environment? So before we get into the details, I want to start by providing an overview of Tenet's clinically integrated organizations. And this is really the fundamental structural unit that Tenet has shaped its ACO strategy around. And the clinically integrated organization, this really includes employed and private practice physicians, hospitals, and ambulatory centers, and essentially physician-led entities, where providers agree to come together to collaborate and coordinate care for the patients. And many of the physicians that are on the call today are part of some such CIO in a Tenet market. And the goal really is to develop clinical initiatives to improve costs and quality, and there are governance and technological infrastructures to support the execution of the larger population health management goals. As a result of these collaborative efforts, we are able to collectively negotiate on behalf of our providers with the health plans. And to the health plans, that is a very strong value proposition of providing a strong provider network base with a broad patient access. And it really is committed to this as a key organizational strategy. We have 16 clinically integrated organizations across various markets, and that represents about 75% of our hospitals. And 14 of those CIOs are contracting with private payers, and 6 are designated as Medicare ACOs, and have more than 600,000 covered lives in total across those arrangements. And up to the types of arrangements that we have engaged in a minute. But really what I want to highlight is there's a national presence of us to deliver on scale, economize, and invest in sophisticated analytics and resources. And again, that makes for a very attractive proposition to payers as we engage them in this dialogue. So Tenet has engaged across a spectrum of a wide variety of value-based reimbursement arrangements. We are in the pay-for-performance space, which is largely incentive-based and includes, that's included in most of the health partner arrangements that we have today. We have actively engaged and continue to add shared savings types of ACO arrangements and have more than 60 private sector ACO arrangements. We participate in 6 Medicare ACOs, like I was mentioning about. That includes 1 year ACO as well. We have taken on full risk capitated payment arrangements in California. So the key thing to note here is that we are gaining experience as an organization across the various types of value-based payment models. And we can really work towards capitation over time and in the coming years. I want to invite you to share your thoughts here. What are you seeing nationally across other provider arrangements as it comes to the experience in the value-based reimbursement model?
Thank you, Dr. Sharon. So, this looks to me like what we're seeing from everybody else on the leading edge. So, we're not seeing organizations, and I spoke to this a little bit in the previous slides. See organizations jump from fee-for-service payments straight to full risk and capitation. You tend to see a smattering of activity as you go from fee-for-service all the way to something more like a global or capitated payment. And it would, frankly, when we're reviewing applications for new ACO models, we like to see a bit of that distribution that or over time that you started, maybe you stepped in and it was pay for performance for quality measures, and then you grew to taking some sort of risk, maybe for a bundle or an episode, 1 episode, 2 episodes, 3 episodes of care. Maybe you start to work out how in your physician compensation structures you're not being paid at an organization level based on quality and cost, but then paying physicians based on our work RVUs solely. But you start to work in maybe some bonus or gain sharing that is related to how well they perform at producing population health and higher quality outcomes and better cost, and then you graduate again to more of that risk. That this is a distribution that seems consistent with those organizations that are on the leading edge. I will also say that it doesn't necessarily mean the end game is full risk for everybody. I think we get asked a lot, and in the healthcare industry and at CMS, we tend to talk about what's the end game. Is it going to be ACOs in the very end? Is it going to be full capitation? It's going to be whatever we think as an industry and as government is going to most reliably support patients and physicians and their care teams achieving optimal health at affordable cost. I mean, that's the end game. And in some sense, there's never an end game. We're always going to be in this cycle of improving. And we feel really positive about some of the alternative payment models and the chance they have to at least own the payments with the kind of care many of you went into practice to conduct.
That's good to hear, Meg. So, moving on, what's the infrastructure that Tenet has in place today to support those kinds of ACO arrangements that we have? And it's really the type of infrastructure that we have developed and in some areas are working towards developing that really needs to be able to support our broader objectives in care management and population health. And to that end, our clinical care management model focuses on collaborating, partnering, and engaging with the stakeholders across the continuum, be it providers, health plans, or members. Our role is to integrate providers with actionable information, drive quality and utilization performance, empower members to take active part in healthcare, and for the health plans, the value proposition to facilitate development of innovative payment models, high quality and cost-effective products. And what further supports and strengthens this model is alignment of the financial incentives to manage costs and quality, integrated information through the exchange to fully execute on the model. So let's start by reviewing the data infrastructure that we have in place. There's no doubt that data analytics and infrastructure is critical to the success of an ACO, where we need to be able to consolidate and digest a variety of sources of data and information to be able to generate actionable information. In that space, Tenet has begun to build an ACO clinical database where today the primary input that's being sent into that database is the health plan or the payer information. It includes the claims data, the pharmacy, and the utilization data, from which we're then able to generate performance reports to really provide actionable insights to physicians on the front line, able to generate data for care management interventions and outreach by ACO clinical care coordinators, and also further risk stratify the population and identify the opportunities where it may relate to clinical interventions, chronic care, and disease management opportunities. Frankly, the next level of data integration will include bringing in the lab data and also better understanding an opportunity to bring in EMR information that will then begin to provide a more complete picture in terms of patient outcomes, where are the key areas of opportunities, and also providing an understanding of longitudinal patient records. Here is an example of the set of reports that are generated and distributed to the providers today in our ACO arrangements. And this type of report is the patient attribution list and the in care, where outlining the opportunities for attributed members that may be due for certain preventative screenings. And I will show you an example of this report in a moment. And another type of report is educating the providers on in-network versus out-of-network utilization, where the member is going for their care. We'll talk a little bit detail more later in this discussion. Then here is to really bring actionable and focused information to providers and practices on members that are attributed to them. So providers have a better understanding of how their attributed members are doing, their opportunities may lie in patient engagement, and improving their quality scores as well. An example of a PCP attribution report that was distributed. What this report lists is all the attributed members in a given practice with identified care opportunities, the three of the measures, and in this instance that includes hemoglobin A1C test, mammography, and EP visit in the past 12 months. And how is the ACO team engaging the members through care coordination, and are some of our primary focus areas? Areas are really based on the fact that healthcare is so fragmented and disjointed, and there are so many opportunities that we can bridge the gaps and connect the dots for the patients. And you all know this. You face this in your practices every single day. Patients may have their care provided at various care settings, but really do we see that information is exchanged between the providers that are providing that care? How many times is it that a PCP knows that their patient or member was seen in the ER the day prior or was admitted to the hospital? Not often. And so the first area of care coordination for us is focusing on addressing just that, inviting seamless care transition for patients that were discharged from the inpatient facility or ER, information back to the PCP or specialist in the outpatient setting. So the ACO nurse calls the member at first point of contact within 48 hours after discharge to check in to see how things are going, if there are any questions or concerns that the patient may have. And also taking that as an opportunity to schedule a follow-up post-discharge appointment with the patient's PCP or specialist. And further, communicating and sharing any discharge summary from the hospital or any diagnostic tests that the patient had in the hospital, and communicating and sharing that with the practice. And additionally, taking that as an opportunity, very well recognizing that the patient has that touch point with the provider scheduled. And that's also a great point to address any existing gaps in care where the member may have been due for some preventative screenings. Instances where a patient may benefit from intensive case management, making those referrals to some case management and disease management programs as well. Addressing gaps in care and connecting patients to clinical programs and resources are some additional focus areas as well. A key point that I'd like to highlight here is that there is so much low-hanging fruit and opportunities to engage members. It's so blindingly obvious that before we can get to true population health management, that we need to be able to address these foundational elements so we provide a more holistic and connected and coordinated and collaborative care to the patient. So through our ACO member outreach, I want to share some patient success stories with you all today. And this to highlight some of the good work that's been done on the front line in terms of addressing the gaps and connecting the dots for the patients. A 50-year-old female patient was recently discharged from a Tenet facility where she was treated for COPD. And she followed up with her pulmonologist after discharge, but she had not visited a PCP in a long while. And she was not aware that she was due for a cervical cancer screening and a colorectal cancer screening. So during post-discharge follow-up phone call, Tenet's ACO nurse was able to engage the member, schedule an appointment with the Tenet in-network PCP, address those gaps in care for the member. The patient was happy that there was someone to assist her beyond her sickness and need care for her. Some patients are in and out of the hospital so much that the wellness component is often forgotten. And in the instance here, a 62-year-old female patient went to the ER with dangerously high potassium levels and uncontrolled diabetes. And after stabilized in the ER, she was asked to follow up with her PCP 1 to 2 days and was discharged from the ER. The PCP also referred the patient to an in-network nephrologist. The ACO nurse communicated the patient's ED visit discharge summary to both the PCP and the nephrologist. And additionally, in preparation for the patient's nephrology appointment, she coached the patient to record blood sugar and blood pressure readings, and as well as a current list of medications. And she discussed the importance of a healthy diet and exercise, and additionally worked with the PCP office to enroll the patient in a diabetes education program. And during the outreach, the ACO nurse also had discovered that the patient had not had a Pap smear with a cervical cancer screening since 1987 and was due for a colorectal cancer screening and mammogram. So the nurse was able to go ahead and schedule an appointment with the OB-GYN for all those 3 screenings. So I want to really pause here and make a mention that this really highlights the difference and the impact that we can make and we have been able to make in members' lives. So I want to pause here and get some thoughts from you, Meg. What are your thoughts on the path that Tenet is on as it relates to the transition to fee-for-value environment?
I confirm that it really sounds like the path that the organizations that are with us on the front line are engaging in. I mean, there's nothing that sounds to me like it is off or not in lockstep with what the best organizations are doing to try to transform care. I think what I can't have a view into, and so that should sound affirming, what I can't have a view into is how you're all doing it together. And that's going to make a big difference. This leadership commitment and the resources and getting you the data and engaging thoughtfully in pacing the transition, staying steady and considering the tests of change and the experiments with what additional resources to bring to bear all of that is appropriate. How that it's consistent, I should say, it's consistent with what we're seeing from other organizations who are really experiencing success, and I don't hear anything missing. Like I said, I can't have a view into is how that feels on the ground and how responsive it is and how you engage in it together and how much you each believe it in your bones that this is a path to doing what you've always wanted to do for patients and their families and getting the support you need and have wanted before, but maybe there hasn't been the organizational momentum behind because who's going to pay for that? So, I think we're excited that organizations are with us on this journey at Medicare and are testing it out. Medicare has long had demonstration projects. Since the Affordable Care Act passed, we've been on a real accelerated path of trying some very different things. And I think with the recent passage of what's commonly referred to as the SGR Fix Bill, but for whom the acronym is actually MACRA, Congress is moving us, is moving CMS, is moving Medicare, consistent with Secretary Well's goals down the path of more alternative payment, more payment aligned with quality, and you guys appear to be, rare with the organizations who are really thinking about this and engaging thoughtfully in it. I'm excited.
That's great, Meg. So, keeping all that background and overview and that discussion in mind, what are some of the key takeaway strategies that you in your day-to-day practice can begin implementing today and in order to handle that value transition and begin to see that success and being positioned to be successful in a value-based world? So the strategies that we will discuss today are really focused primarily on the practices and the physicians, and in many instances, practices are stretched thin on the resources, and we want to be cognizant of that. Availability of staff and time are some key constraints. And recognizing that these are constraints, what are the key strategies by which providers can begin to adapt to in a fee-for-value world? And particularly in open access population where patients have the choice to pick the providers and hospitals, and where primary care providers are not necessarily the first points of contact for a member sees a specialist. Strategy number one, engage with the data. Data is central to all things baseline and improvement. And in most of our ACO markets, we have rolled out physician and practice level actionable reports. And from the data that we receive from the payers, we want to design reports that we think will be helpful to the practices. And this includes a membership attribution report and the gap in care report that you saw an example of earlier. And really, there is probably an equivalent of this type of report in other markets where we haven't rolled this out yet. The point that I want to highlight here is there is an opportunity for physicians and practice staff to begin to work together and identify off the attributed list of members and identified care opportunities. How can we begin to outreach to those members? And one of the practices that we heard from dedicates an hour each week where the practice manager or the MA reviews the list or the report and calls the patients to schedule those appointments and bring the members in. That's also due for preventative screening services for a visit. Of course, each practice needs to evaluate on what approach works best. But this is a great way to address low-hanging fruit opportunity here, where it's a win for the patient. It helps the provider as they're able to meet their quality scores, thresholds to participate in the shared savings bonus distributions. And one of the things that I'd also like to hear back from you all today, from the audience, is during the Q&A session, what are some of the additional data elements and reports that you find helpful that are not currently in place today, but some that you would like to see going forward? And this is something I'd love to hear your thoughts on during the Q&A session. Practice strategy number two, building and establishing patient loyalty to the provider and network. A challenge that providers in an ACO world or types of shared savings arrangement face is that an open access network model where members can choose their providers and facilities, but the network is held accountable for the cost and quality of care that members may receive, whether the care was provided in-network or outside of the ACO network. And here's where building and establishing patient and member loyalty to providers within the network is key. And providers can, since they're being providers can communicate and coordinate care better for the patients across various care settings if care is provided within the network. And a key component here is educating the members and making them aware that central to the care that they receive is that providers and facilities are able to talk to each other, communicate and share information, and have access to their medical records across those care settings when their care is within the ACO network. And one of the feedbacks that we have received was providers wanted to see where their members were going or being referred to so that they can re-engage their members and physician peers in conversations around in-network care. So as a result of that, we created out-of-network utilization reports, highlights which patients are going out of ACO network facilities, what conditions are driving those attributed patients to out of ACO network facilities, and also provided a list of top 25 out of ACO network professional providers that the attributed patients have visited. And most ACO arrangements are based on an attribution logic, where members are attributed to the providers based on the providers that they see most frequently and/or have been seen most recently for certain types of E&M visits. This may drop off from a provider that they're attributed to if they haven't seen the provider in a while, and an opportunity to embrace preventative medicine and risk visits. The healthcare reform has promoted access and coverage to preventative medicine services such as physical exams, health risk assessments, and wellness exams, and other visits that focus on the overall well-being and health status of an individual. Again, this is necessary to improve the healthcare outcomes, but also it generates additional appropriate visits that we see in a volume-based world. Strategy number 3, improving patient experience. Health plans, as you know, have routinely administered member experience surveys for a while now, and in the value-based world, this is an integral component of value-based payment models. References to some key member experience questions, such as getting timely appointments to care and information, how well the providers communicated with the patients, shared decision-making, those are all very important. They are being increasingly tied to reimbursement. Additionally, members are going online and posting online ratings of physician practice. If you haven't already, I encourage you to go online and take a look. How is your practice performing currently? Is there something that you can act on in terms of improving patient experience today? And really, members also go online to review those physician ratings before they go ahead and select a physician. And needless to say, this will end up having an impact on the volume as well. And another component to improving member experience is offering flexible access and appointment times, providing some non-traditional appointment hours such as early mornings, evenings, and weekends promotes patient compliance to follow-up visits and is also less disruptive to the schedules of adults and typical school day for children and adolescents. And more convenient appointment times generate that additional appointment volume while improving the patient experience. So at this point, I want to pause and open the line up for a couple of questions. I know we are coming up close to the hour